atherosclerosis. The atherosclerosis is a narrowing disease, mostly due to the formation of so-called plaques. So here we would see a lipid-rich necrotic core covered by a fibrous tissue, and this would narrow the vessel lumen, constricting the blood flow. What's even worse is that this plaque might undergo rupture where the fibrous cap is broken. If that occurs, the content of within the necrotic core will be released into the bloodstream, causing formation of thrombus. This thrombus may further dislodge and travel to downstream, causing blockage of smaller vessels. So things like ischemic stroke, angina, and myocardial infarction are some of the unfortunate consequences of atherosclerosis. The current management is mostly based on the degree of stenosis, or in other words, narrowing, or the burden of the plaque. However, this has been shown to be adequate because the size alone is not quite good enough. As mentioned by Professor Franke's talk this morning, we could use biomechanical factors to allow better assessment. In particular, we are interested in either the PSS, the plaque structural stress in the solid domain, and wall shear stress in the fluid domain. They can both be estimated with in vivo medical imaging. So the modeling process typically starts with the reconstruction of the geometry. Although I'm presenting some coronary cases, but because carotid has been the vascular bed that has been most extensively studied, I will show the procedure with the carotid arteries. Normally, we would have a series of images obtained in vivo, from which we can delineate the contours, the size, and also the different compositions of the carotid plaque. With this, we can either build a 2D model or stack them together, extract the isosurface, render it into a volume, and further divide them into smaller blocks known as elements, and hence the name of finite element method. So we'll be, the model will be subject to a few equations, such as the Cauchy momentum equation in the solid domain, the famous Navier-Stokes in the fluid, as well as the Mooney-Rivlin formulation to describe the tissue behavior for each component. So the parameters of C1, D1, D2 would describe how the tissue moves when a given force is prescribed. So these are actually measured using the samples we collected from the operation theater. So once we got all the pieces in place, we can then apply external loading and fixities. And the beauty of nowadays software is that the solver would typically do it for you. You don't really have to solve all the equations yourself. Then depending on the complexity of the problem, you can either go to the kitchen to bake a cup of tea or enjoy the day off without really feeling guilty. Yeah. So in the last few decades, there has been a number of studies to look at the actual role of biomechanical forces or stresses. It is well agreed that a low or oscillatory wall shear stress associates with the plaque initiation. And in a paper about 2 years ago, we also verified the idea that the high plaque structural stress was indeed present in the ruptured lesions, as evident by the OCT imaging and grayscale IVUS. But the story is somewhere missing between these two ends. So we're not entirely sure what are the roles of the stresses during the growth and destabilization of the natural history of plaques. So this is why we designed two studies. The first one involves 40 patients recruited in the US, where patients undergo both baseline and follow-up imaging with an interval of 18 months. The imaging modality here is called the virtual histology intravascular ultrasound, because it's really too long, so we typically call it VH-IVUS instead. And all the images are already pseudo-colored, with the red represents the necrotic core, green represents the fibrous tissue, and white represents the calcium. Cardiologists told me that this color scheme was actually chosen to be intuitive, so that red is bad, green is good, and white is boring, such as the bone. So during the follow-up, we saw both changes in size of plaque, either being progressed or regressed, as well as changes in the composition either in the green or in the red. So we are therefore interested to see whether such changes correlates with the pattern of the wall shear stress in the fluid or the structural stress in the solid domain. So what we found is that, similar to some previous literature, a low wall shear stress would be associated with increase in the plaque area and plaque burden. This is mostly driven by an overgrowth of the fibrous tissue. But other than this, the role of wall shear stress is relatively minor and difficult to interpret in the plaque composition. The structural stress in the solid domain is quite the opposite. We don't quite see much changes in area because of that. However, if we do see baseline high PSS, we are more likely to see a growth of the red necrotic core, but a decay in the green fibrous tissue. If we recall the idea that red is evil and green is protective, then this means that the plaque that has baseline high PSS might be growing into a more dangerous phenotype that are more vulnerable to rupture. So in other words, this study indicates that wall shear stress in the fluid domain will be more responsible for changes in stenosis, while the structural stress are more closely associated with the change in vulnerability. So this is quite encouraging because it actually tells us that the stresses are actually doing something, or at least indicating something that could be used for follow-up. And the question would be whether we can identify plaques that would proceed to future events. This is just an illustration of idea. So if we do have two plaques with similar plaque burden, we can calculate the plaque structural stress, look at its absolute magnitude, and also the heterogeneity across the vessel to identify the one at higher risk. So to be able to do this, we again use another cohort from the US. It's the famous PROSPECT cohort. It involves about 700 patients with acute coronary syndrome. And during a follow-up of over 3 years, 35 non-corporate lesions at baseline developed into a major cardiac event, major adverse cardiac events. And of course, in order to have a control group, we also did propensity matching with 66 NCL that remain silent. Compared to the previous study here, we won't be doing a frame-wise comparison because the only information we know at the endpoint is whether this vessel has event or not. Therefore, we need a vessel-wise assessment of the environment. Well, physiology and also the idea of remodeling tells us that the tissue would actually prefer a more homogeneous environment, and the severity of the disease can therefore be somehow reflected by the heterogeneity of the stress within the vessel. And therefore, we look at the PSS profile along the vessel longitudinally and define use a very standard coefficient of variation to describe the dispersion of the value. So this is simply as the standard deviation divided by the mean value. So with what we found that both the absolute magnitude of PSS and the heterogeneity were increased in the thin cap fibrous atheroma that developed the maze in the future. And more interestingly, if we, on top of the plaque burden, minimal luminal area kind of feature, these are the features which we could extract from IVUS directly. If we also incorporate the PSS and its heterogeneity, we will be able to get a better stratification of patients, of the non-corporate lesions that lead to future MACE. So this is published recently at JACC Cardiovascular Imaging. So as some quick conclusion, in the two recent studies, we found that biomechanical stresses associate with the growth and destabilization of coronary plaques. This is either reflected in the changes of the size and composition, and also the likelihood for future events. The integration of the modeling and intravascular imaging may help to identify the high-risk lesions or even high-risk patients, but prospective studies are still needed. So far I've been talking about a more model-based approach, but there will certainly be lots of developments needed to make it towards clinical translation. The first one, of course, will be to get some more accurate presentation of geometry, moving from the paving-based algorithm to an octree-based algorithm, for example. The second part will be to combine the model-driven to data-driven approaches. We can use some deep learning technique to allow faster computation of the stress map. So this is work done together with Imperial College, a colleague named Yuan Huang, who used to also be a postdoc at CMH. And also we could aim for much bigger improvement by integrating with other imaging modalities, such as optical coherence imaging, optical coherence tomography, or OCT. So this is work by my colleague, Adam Wolf, where he used deep learning algorithm to segment the cap thickness, the fibrous cap thickness, which we could use for finer modeling. And last but not least, we should, just like the carotid case, we should be moving from 2D structure-only models to 3D models with consideration of both fluid and structure. So this will allow us to get more realistic estimation of the loading, as well as accounting for the bending due to the heartbeat. So of course, this is the work of joint team effort. It won't be possible without people at either the southeast or northwest of Cambridge. And also we got a few key external collaborators who were so kind to allow us to use their clinical data set to perform the analysis. So yeah, this ends my talk, and many thanks for your attention.
Okay, thank you. Any questions? So can I ask you a question? So when you said the construction from the coronary is more difficult than the carotid imaging, what's the difficulty of this?
So I think that comes from two sides. So here, in carotid, we are already doing 3D FSI for a long time. It's less of common practice in the coronary, I think, for two reasons. The first one is about the imaging, the limitation of imaging modality. For the carotid case, we have a whole volume of MR, so it will be easier for us, way easier for us to extract the ISO or the level sets and ISO surface. But with coronary, this is actually an invasive technique. All the images were based on a pullback using a catheter. So the interplane distance and will vary depending on the heart rate and also pullback speed. Also, the catheter itself might not only bend but twist in its principal direction, which is giving us quite some difficulty to make sure that the reconstruction is accurate. Also, for the reference imaging modality, we don't have a whole 3D volume, but we only have a biplanar DSA instead. Although we can reliably get the central line, the actual luminal boundary may not be that reliable. So these are the limitations and difficulty coming from the imaging. And another thing is that the coronary itself is a lot smaller compared with carotid. And also, it's, if we're doing a 3D modeling in carotid, we don't really have consider things like the bending due to heartbeat. We're just considering the change of the waveform and the flow. But with coronary, because the heart is also bending, you will be getting some external motion, not due to the blood pressure, but due to the motion of the heart as well. So this makes things more difficult to track with.
It seems we still have lots of technical problems.
A lot of, yes.
Okay, good luck. Okay.
That's definitely needed.
Okay.